be presenting on lingual thyroid. I'm Dr. Agatha Bizos, one of the registrars at UCT. I'd just like to acknowledge Dr. White for his assistance and preparation for this presentation. These are my disclosures. So I'd like to present a case of a 61-year-old female, background hypertensive, PSA1, who was planned for hip replacement of a traumatic neck of femur fracture at a peripheral hospital. Clinically, preoperatively or pre-anesthetic, there was no airway concern, but during intubation, there was difficulty due to a base of tongue mass. There was hesitancy in extubating the patient post-operatively, and so the patient was transferred across to us intubated. The patient was transferred to ICU and we booked her for DLTB and suspension laryngoscopy, where we appreciated a large, well-circumscribed base of tongue mass, which originated from the foramen cecum and extended to the valleculum, but spared the epiglottis. Clinically, the patient had no palpable lymph nodes, and the decision during that time with the on-call team was not for trial of extubation, and a tracheostomy was performed. One can appreciate on this video the lesion, which is a well-circumscribed large base of tongue mass. And even if we place the CMAC a bit further down, you can also appreciate how the epiglottis is completely free of this mass. Multiple biopsies were taken intraoperatively, and marked bleeding was noted during biopsy of the lesion, as there was increased vascularity of the well-circumscribed mass. We took multiple deep biopsies trying to get to the core of the lesion to aid us in diagnosis. One can appreciate how vascular this lesion in fact was. On CT scan, one could appreciate on these axial views a well-defined heterogeneous iodine-avid base of tongue mass. And there's no associated lymphadenopathy. And one can also appreciate this again on the sagittal view. This area. And there was no associated lymphadenopathy, which can also be appreciated on CT scan. Further investigations that were performed included, or preoperatively, in fact, was a CNP and thyroid function test, which were both normal, and the patient was euthyroid. And so we'd go into our differentials of a base of tongue mass, which could include infectious, congenital, or neoplastic lesions. In terms of congenital lesions, we can define them further or differentiate them further into non-vascular lesions, where our differentials would include a lingual thyroid, a thyroglossal duct cyst, a dermoid cyst, epidermoid cyst, lipoma. In some of the literature, it mentions a foregut duplication cyst or even a hemangioma in this lesion. And then in terms of vascular lesions, one should always be aware of lymphatic malformations, venous malformations, venolymphatic malformations, and AV malformations. In terms of neoplastic lesions, multiple benign lesions could be part of the differential, including minor salivary gland tumors, rhabdomyomas, schwannomas, neurofibromas, leiomyomas, and plexiform neurofibromas, as well as lymphoma. And in malignant lesions, squamous cell carcinoma accounts for approximately 90% of oral cavity or oropharyngeal neoplasms, so should always be on high part of the malignant differential, as well as mucoepidermoid carcinoma, which macroscopically mimics an ectopic thyroid. And it has been well described in the base of tongue at various presentations. The differentials of malignant lesions include the following as listed on the screen. So for the specific patients, the multiple fragments of tissue came back from the histopathologist, which confirmed that the patient in fact had an ectopic thyroid gland, ectopic lingual thyroid. And so we can go into a bit of this lesion. It was first described in 1869 by Hickman, and it's essentially a failure of the thyroid descent, with only 20 to 30% having separate thyroid tissue. It's due to embryonic failure of descent from the base of tongue to the mediastinum along the path of the obliterated thyroglosal duct, and the prevalence is extremely rare. It's reported 1 in 100,000 to 300,000 persons. It typically involves females. There's a female predominance, predominantly during, and particularly during puberty, pregnancy, or menopause, when the plasma TSH level increases in the body, leading to hypertrophy of this ectopic tissue. Malignancy or malignant transformation is estimated about 1 per 100 cases, so it's quite rare, but should always be kept at the back, or should always be kept at the back of the mind when dealing with these lesions. And it's typically an incidental finding, with sometimes having more than one ectopic site of patients can have more than one ectopic site of thyroid tissue. And why is it important? Well, ectopic thyroid tissues can be the only thyroid tissue which is present in about 75% of patients who present with lingual thyroid, and a high percentage of these patients are in fact hypothyroid. And so the identification and management, since it may be the only functioning tissue occurring in the body, is quite significant. If we look at the embryology, which would help us understand how this lesion comes about, the thyroid gland is normally located in the anterior neck, region between the second and fifth tracheal rings, and it is developed approximately on day 24 of gestation. The thyroid primordium originates as a proliferation of endodermal epithelial cells in the floor of the primitive pharynx at the foramen cecum, which is located in the midline at the junction of the anterior 2/3 of the tongue, which is the first branchial arch derivative, and the posterior 1/3, which is the third branchial arch derivative. During the 4th week of embryonic development, this occurs, and subsequently during weeks 5 to 7 of gestation, the gland enlarged penetrates the underlying mesoderm and descends to the pharyngeal gut as a bilobe diverticulum through the tongue in the neck, passing anteriorly, but it also can pass posteriorly to the hyoid bone and thyroid cartilage to reach its final position. During this migration, the thyroid gland is attached to the foramen cecum by a narrow tube, the thyroglossal duct, and this duct is normally obliterated and usually disappears. And so ectopic thyroid is a rare congenital anomaly that arises from the aberrant embryogenesis during this migration, where there may be a persistent thyroglossal duct. It most frequently occurs in the lingual thyroid, but it has been reported as occurring in other places or located along the path, the midline path of the thyroglossal duct. And it also can rarely present lateral to the midline in the submandibular areas, as well as lateral cervical areas. And it can even present substernally, and this would be due to an overdescent of the thyroglossal duct, where one can find ectopic thyroid tissue in the mediastinum and mid-subdiaphragmatic locations. Symptoms of ectopic lingual thyroid include endocrine dysfunction. 1 to 2/3 of patients are in fact hypothyroid, and some or minority of patients can be hyperthyroid. Hemorrhage, patients can present with hemorrhage from the lesion, may have just specific symptoms of sleep apnea, and the most common presenting symptoms in severe cases of patients with dysphagia, a globus sensation, dysphonia, dyspnea, and in the rare occurrence, airway obstruction. So this is how clinically it usually appears, and the common clinical finding is enlargement of the posterior base of the tongue by a firm midline mass. The surface of the lesion is usually smooth or lobulated, as one can appreciate in these images, and the color may range from bluish red to pure red. The hypertrophy of lingual thyroid occurs in response to TSH stimulation from physiological demands, and usually the thyroid hormone production from the lingual thyroid often cannot meet the normal physiological needs of the patient, which is why it results in enlargement of the gland. Histologically, the lingual thyroid is essentially similar in normal thyroid parenchyma to a normal thyroid gland. And just some clinical points. So 90% of ectopic thyroid tissue is associated with the dorsum of the tongue in the midline, and it's the majority of these patients have thyroid ectopia, which is an umbrella term for patients having no other thyroid tissue on the neck. So one would start with investigating the patient by doing normal biochemistry, biochemistry which should include thyroid function tests as well as CMP to assess the functioning of the gland, and then can move on to imaging. Ultrasound of the neck will help to confirm the presence or absence of a normal cervical thyroid. And if one would need to go on to further imaging, including CT or MRI, it can be useful when the thyroid or utopic thyroid gland is not identified by ultrasound. CT scan with contrast of an ectopic thyroid tissue has this characteristic uniform high attenuation, and on MRI, ectopic thyroid tissue appears as a rounded mass with a high signal intensity than that of the surrounding tissue and muscles in both T1 and T2 weighted images. MRI can be particularly useful in lingual thyroid when there is difficulty in differentiating the thyroid tissue from the tongue muscle in terms of preoperative planning. And if one has a concern of malignancy, CT can assist with what can help us delineate whether there's malignant transformation on imaging. Radioisotope imaging or thyroid uptake scan is a radiologic diagnostic tool used to determine the thyroid function and pathology of presence, and also to confirm the presence of ectopic thyroid tissue. And it would play a central role in the diagnosis of thyroid disease or abnormality in thyroid function. if one is suspecting thyroid malignancy, metastases of thyroid cancer or thyroid nodule inflammation. And a sleep study should be done in patients who present with symptoms and signs of obstructive sleep apnea, in able to manage them further and understand the severity of their obstructive sleep apnea. In terms of management, conservative management or the treatment modality of choice always depends on patient factors, institution factors, and surgeon factors. And the mainstay of treatment is conservative, which involves hormone suppression treatment with exogenous thyroid hormone, as this can help shrink or suppress the size of the lingual thyroid and give a reduction in the size. But if obstructive symptoms, if the patient presents with obstructive symptoms or hemorrhage, there will be a need for surgical management, which would include the possible need, in addition to resection, or the need for a tracheostomy. And in terms of resection or surgical management, the indications for surgical intervention would include high-risk symptoms of the patient at presentation, if there's a concern of malignancy, or if the patient is resistant to conservative therapy. In terms of total versus subtotal resection, total resection is recommended or advocated for, as there have been reported excellent functional outcomes of patients who present with lesions that measure less than 50% of the base of tongue. And the other argument for this is that it's a hypo-functioning gland with no hormonal benefit. There are also the associated risks of subtotal resection, which include the risk of malignant transformation, residual clinical symptoms such as globus sensation, and increased risk of bleeding by transecting through the thyroid tissue. So we do recommend total resection of the ectopic lingual thyroid. And the transoral approach offers an acceptable morbidity in most patients, and most patients experience resolution of symptoms following this approach. There are multiple different ways in which one can resect the lesion transorally, which include monopolar coagulation, TLM, and recently TORS has also been shown to be effective. And there's, as we said before, increased functional outcome with decreased morbidity in a transoral approach. Extraoral techniques would only be recommended for very few select cases where this mass is not amenable to transoral excision, but it comes with its own risks and increased morbidity. So in terms of our patient management, no further investigations were performed. The patient was counseled on the clinical findings. She was decannulated and discharged after 24 hours of observation with no obstructive symptoms. And so I'd like to just discuss quite a nice systematic review by Sauer et al. on the surgical management and whether it still plays a role of ectopic lingual thyroid. In the paper, it describes the following: that the incidence is rare. It usually affects females that are with a very small proportion that are symptomatic, but hypothyroid, and there's a very low risk of thyroid carcinoma. In this 36 patient institutional cohort of 224 systematic reviews, the symptoms defined as high risk were dysphagia, dysphonia, dyspnea, neck swelling, bleeding, and obstructive sleep apnea. And so the recommendations put forward are: if the patient is asymptomatic with no concern of malignancy, observation is advised. If there are mild symptoms or if there's hypothyroidism of the patient, then a trial of thyroid suppressive treatment or radioactive iodine can be implemented. And if medical management fails, or if there's concern of malignancy, then total resection of the gland is recommended, with a very low 4% chance of a transoral bleeding rate. So in conclusion, ectopic thyroid is quite a rare entity which affects females with a low malignancy risk. Initial management should always include airway management and anesthetic considerations should the patient need to go to theatre. And the treatment modality of choice is based on patient, institution, and surgeon factors. But we do recommend the following algorithm in terms of management of patients who present with these types of lesions. These are my references. Thank you.
Thanks, Aggie. It's an interesting case. I was just wondering if you came across anything about if there's any association with parathyroid ectopia. I would have thought not. It's different.
So in
neurological arch.
Yeah, so none of the articles that I read did describe parathyroid ectopia along with the thyroid ectopia. So it's, I don't think, a common association.
Any questions or comments?
Could I comment?
Yes, Bob.
Yeah, thank you very much. That was a wonderful presentation. I was just going to ask Matt, if you'd done a thyroid scan and showed thyroid tissue, would you have proceeded to a biopsy?
Apologies, Bob, if we did a radioactive isotope scan. So my initial concern, as you know, I wasn't there for the initial emergency, was that, but now having seen the video, I'm a lot less concerned, is that perhaps maybe the initial biopsies were just a bit superficial, and we maybe just biopsied the capsule, and we hadn't completely excluded an underlying thyroid malignancy. But now knowing, with subsequent reading the literature, that the risk of differentiated thyroid carcinoma is firstly low at less than 1%, and also in view that there was it was very well defined on the scan, and there were no associated cervical lymph nodes, no evidence of distant metastases. It wasn't infiltrating other tissues. It wasn't kind of radiologically concerning as a malignancy. But at one point, I did consider doing a radioactive isotope scan, which I did discuss with Dr. Neri, who's our head of endocrine surgery. Might add some value in that if it was a cold lesion, then one might be more concerned of the malignancy, whereas if there was significant uptake or a hot lesion in the base of the tongue, then the risk of associated thyroid malignancy would be very low. But having kind of seen the nature of the biopsies now and taken the whole clinical picture into account, I probably don't think it's necessary. I don't know what you think, Rob.
Yeah, so yeah, I agree with you. I mean, if you confirm this thyroid tissue, and you can do that through with a scan, then as you point out, if there are no other features suggesting malignancy, then that's probably all you need to do. That's my sense.
Okay, thank you for that, Prof. Are there any more comments or questions? If not, then we will end our meeting and see you again on Friday. Thank you very much.
Thank you.